Well, today we're here to talk about what I think is among the great and most important uncertainties, and that is this question in healthcare. Will value actually replace volume in healthcare? And I want to make the case that the signals are no longer weak. The signals are growing very loud, and it's become abundantly clear that that is true and that we need to prepare. So a value payment would be when a material part of a healthcare payment is contingent either upon health outcomes or financial outcomes. They take a number of different forms. In some cases, it could be bundled payment, where a procedure or a condition, a lump sum is paid, and then there is a coordinator or convener, as we know it, that will in fact then adjudicate that process and assume the financial risk for having it being done well. Hence, the value payment. Or it's gain sharing against a baseline, where we establish a baseline of expenditures on a population and say to a group of healthcare providers, if you're able to provide quality care and keep the cost below that benchmark, we're going to share the benefit of that. In some cases, the benefit is upside and downside. In other words, the proposition is we're going to pay you slightly less on a guaranteed basis, but if you do better than average, we're going to pay you more, and if you don't do as well as average, you'll suffer part of the consequence. In other words, part of the outcome is based on either a health condition or a financial condition. And lastly, full capitation. This is, of course, when a group of healthcare providers assumes full responsibility for payment. So what are the weak signals about this? Well, I'm not going to go through all of this, but let me just say it is, in my mind, no longer a question that we're seeing this movement rapidly expand. Here's one interesting point. CMS has established a goal that, think about this, 80% of payments will have some level of financial accountability by 2018. Now, I need to tell you, I'm skeptical they'll make that. But the fact that they made the goal and the fact that they are now establishing a whole series of programs and procedures to back that up tells me that the biggest payer in the world for healthcare is very serious about that. So here is the conclusion that I'd like to lay out today in the context of our conversation. The weak signals are no longer weak, and that this transition of value-based payment is the most significant change in healthcare since the widespread adoption of employer-based health insurance. To miss it, to ignore it, is to be disadvantaged in a substantial way. To a large extent, this is about better coordination, and it's about who assumes risk. But the reality is, we're not very good at this, and it's hard. And we're having to learn new skills. But that's okay, because we are clearly moving this direction, and those who move and who honestly begin to do the work will in fact find that this is a remarkable opportunity for them. Those who lag behind, I think, will be what we know as the laggards on the diffusion of innovation curve. They'll be behind the curve. It'll be safer, but they will be disadvantaged by it. So how is it that we are asking them to be part of it, and how is that unfolding? Well, I would suggest in a couple of ways. The way we bill for health insurance. I now have a health savings account. My health is now an economic incentive for me. A lot of employers who are larger employers are saying your premium, if you are above X on your BMI, is going to be $1,400 a month, and if it's below Y, it's going to be $800 a month. And we can demonstrate to you that that's fair. Now, my point is that we're a bit ham-handed in the way we're going about this, but we are in fact beginning to engage consumers in the decision process as we, and this is a slow process. It's a bit like smoking. 30 years, smoking has changed dramatically in terms of the way we socially perceive that. If you look at the 1990s, there are a couple of things that are different. One is that we didn't have, at that point, an $18 trillion debt. We didn't have India, China, Brazil breathing down our neck to become the leading economy in the world. We didn't have a global economy. We didn't have a level of competition that we have today. I would argue we also didn't have many of the technologies of today that will allow us, for example, risk adjustment, the ability, the science of how we go about actually being able to pay the appropriate amount for the risk. But I would tell you we learned two very important things in that process over the 1990s. The first is that people really don't like insurance companies telling them what they will kind of care they can provide. And the second is that if you're going to be a doctor, and so we're going to let them make the decisions. The reality is we're going to let the care deliverers make the decisions. But there's a second part of the equation, which is different. And that is, we're going to have you assume financial responsibility, not just the insurance company. I think that's the primary difference, that we are compelled economically, the problem is more mature, and we're changing the model. Instead of simply having insurance companies make the decision, we're going to let care deliverers make the decisions, but we're going to hold them financially accountable to provide value. Now, that's one of the reasons I say this is a 40-year proposition. You have to look at those experiences as part of that. And what did we learn? It's a wonderful illustration to me of how transparency, not just in cost, but give people some relationship on quality, even if it's something ham-handed like stars, but give them something to gauge that the $8,600 one is the same as the $2,900 one. That's transparency. And I think we're beginning to see that develop in the marketplace, and it'll clearly be part of what makes value work for consumers. I mentioned this large clinical operation that has over 1 million lives. They have a very robust data system. And one of the things in their data system they determined was that, you know, their magic formula is just keep people out of the hospital and treat them in the lowest possible, the lowest cost and most efficient way. Obviously, prevention is the biggest of that. If we can, and so they started bringing house calls back because they could deploy a physician to a home more inexpensively than it cost them to pay for the emergency room. So they would have people who just get in the car and drive. Then they just made a really interesting discovery. And that is that a lot of their older patients were in fact coming because they were lonely. And they just liked the sociality of going to the doctor's office. And they hired a little team of people to just basically go around and have tea and biscuits with people who fit a certain profile. And amazingly, they turned up at the doctor's office less. So there's all kinds of things that we're going to discover that we never would in a fee-for-service basis because it's uncoordinated and because the financial responsibility all just equates to more. The more times they show up, the better we like it. Until we have a responsibility, and then we're going to hire somebody to go have tea and biscuits with them because it'll give them good care. And I'd just like to leave you with this challenge. We're talking about very serious change here. When it comes to change like this, you really only have 3 choices. You can fight it and die. You can accept it and go along, or you can lead it and prosper. And my challenge to you today is that what's made the United States of America the greatest country in the world is that we have been willing as a people to lead. Whether that means changing the way we exercise and diet as individuals, or whether it means changing the way we practice and the way we organize and the way we get paid. If you fight it, you'll be overcome by events. If you accept this, you'll have a chance. But if you lead it, you will prosper. And my challenge is that you lead it and prosper. Thank you.